Good. Okay. Well, first of all, I just wanted to say thank you for having us to WINBACK, to the team who helped coordinate this. And thank you to all the participants who signed on in all different time zones. We are about the middle of the day over here in the East Coast. So welcome. So what we're going to talk a little bit about today were how we in our practice here at Johns Hopkins use WINBACK for a few different of our cases, patient scenarios in pelvic health. We started the WINBACK here at Johns Hopkins. I believe we got it about 2.5 or 3 years ago, our first unit. And it has become a very quick go-to treatment tool, especially for our pelvic health team. And so we've gotten to collaborate a lot with WINBACK and learn about all the different ways to use it that have really made a huge difference for our patients. And so Teasley and I are hoping to share a few case scenarios and show how we apply it. So to give a little background on myself first, so my name's Mary Austin, and I am currently the residency program director here at Johns Hopkins. So we have postgraduate programs that formally mentor and have curriculum to train physical therapists in a specialty area of care. And so we just started a pelvic health residency here 2 years ago. Teasley was our first resident, so you'll get to hear from Teasley as well. And I also oversee our pelvic health service line, so the other pelvic health therapists. And I personally have treated only pelvic health for 12 years. So women, men, transgender, all ages, anyone with a pelvis, I will treat a variety of diagnoses. I've had the pleasure of doing some research in the past, and I'm also an instructor for the Academy of Pelvic Health for the American Physical Therapy Association. And then I'll let Teasley introduce themselves.
Hi, my name is Teasley. I use they, them pronouns, as you may have heard. As Mary mentioned, I was last year's resident here at Johns Hopkins, and I have been pleased to accept a full-time staff position here, treating 100% pelvic health diagnoses now, all genders, all sexes, primarily adults. And in my background is I am West Coast trained, UCLA and USC, and then I moved out here to Johns Hopkins to Baltimore to do this residency. I've achieved my CAP certification, which is a certification through the Academy of Pelvic Health PT, and I am in the process of applying for and studying for the board specialty exam.
Okay. Sorry, I kept going out and out. So to give you also just everyone a little background about what our practice is like. So we are a hospital-based setting. So we're all fall under the umbrella of Johns Hopkins Hospital, and we have a main hospital clinic, which is where Teasley is located and practices 100% of the time. And then we have satellite clinics throughout the Baltimore kind of DC region. And so we are associated with a hospital, but we are outpatient-based practices, if that makes sense for you. And so we aren't independent private practices. So in terms of our patient demographics, you know, I put on this slide here a list of our common referring providers, which is quite the range. So traditionally, I think people think pelvic health and think all women's health and kind of pregnancy postpartum. We certainly see that, certainly treat definitely more postpartum than pregnancy in our particular practice. But really, we have cast a wide net. So we see a ton of patients referred to us from the urology clinic, from gastroenterology, from our orthopedics, behavioral health, transgender clinic. So really, as I kind of alluded to, any pelvic health diagnoses we will treat. So whether that's incontinence, constipation, pain associated with interstitial cystitis or endometriosis, maybe trauma from a 3rd or 4th degree laceration during a delivery, you know, post-vaginoplasty, maybe patients have had uterine or endometrial cancer and they end up having a hysterectomy and then some resulting pain. So kind of any scenario you can think of, even patients with a lot of neurological disorders, as you're going to see in some of our cases as well. So what we were hoping to do today was highlight a couple cases where the WINBACK really came to the rescue, so to speak, right? After working for several years, when new technology kind of comes my way, I'm always cautiously optimistic about it. I kind of give it the benefit of the doubt, but I'm pretty specific about how I implement it to see if it is like that factor that made the difference in the care. And so this first case is a good case. I kind of go into a good amount of background and detail on this patient because she is so complex, and I had been working with her for quite some time before we even had the WINBACK as a treatment option. So I kind of wanted to layer this case to show you the various different treatments I did, and then how kind of WINBACK made a nice difference, and kind of sold. Honestly, this case is what really sold me on thinking the WINBACK was effective. So this particular patient, so she was a 45-year-old female when I first met her. She had been pregnant one time, had one vaginal delivery, and really her big symptoms were that she really had infrequent bowel movements. So she could maybe go once or twice a week, if that. She really never ever felt like she emptied when she had a bowel movement. She strained a ton, and her stool consistency was kind of all over the board. And the other big bother to her or symptom was that she had really significant abdominal distension or bloating and severe pain anytime she ate anything. So, you know, it's a type of thing where a lot of people will say that, but they look, fine. They don't look like they have some bloating or distension. But with her, she would come in and she's a very thin, petite woman. So that distension is very pronounced on her, and I would see it time and time again. So I believed it, right? The big complaints that all of these symptoms really posed for her issues was that she had a 5-year-old daughter and really had a hard time participating in taking her to and from school, taking her to soccer practice, like doing all of these day-to-day activities you would do with your child. But her bowels really dictated her day-to-day routine. She really had a hard time exercising because of all of the pain and distension. And also she was pretty depleted energy-wise because of all of the pain with eating. She restricted her eating a lot, therefore. And socially, she comes from this big Italian family, right? And they center everything around these big meals and holidays, and she couldn't eat, right? And she was in pain. So it really impacted her every day. So what brought all of this about? So her significant medical history is that when her daughter was 6 months old, she was diagnosed with a benign meningioma of the left brainstem and cerebellum. And it was pretty significant in size. And so she immediately had to have surgery. So they did a left suboccipital craniectomy and posterior fossa mass resection. So in that area down right, if you can see my cursor, can you all see my cursor? Yeah. Okay. So really at the base of the brainstem, now it's of course not working. There we go. At the base of the brainstem here, and that part of the cerebellum and part of the brainstem were what was resected on this particular patient. So immediately after the surgery, she had really significant left-sided weakness, ataxia, really impaired motor control. It was almost like she was presenting with like a hemiparesis or almost like a stroke. And then this is really when her constipation started. So she immediately went into PT for all the neurological symptoms to really help with her balance and gait and traditional things you would think of. But no one addressed the constipation right away and didn't really see the connection to her brain surgery. However, if you kind of get into the weeds of kind of the brain centers of what controls constipation or what controls bowel function, a lot of people think it's all very lower level or more peripheral nerves. But what this graph illustrates nicely is you can see that red arrow on the brainstem, again, like indicating the area of her tumor and then the site of resection. And it really follows suit with this, of that she had a compression injury probably initially from the tumor, and then they actually resected that area. So she also had resulting scar tissue in that area. So that would classify her as one of these kind of high cord lesions at that brainstem. And one of the significant resulting effects is colonic mobility reduction or delayed colonic transit. which is really how this patient presented. So this is, again, just another schematic as a reminder to everyone of kind of the complexities of all of the neurological contributors to just having a regular bowel movement. So all these things, right, that I tell people, like, you take for granted until something goes awry, right, until something goes wrong. And so, again, it just kind of highlights at the top here, you see that sympathetic trunk, and that is right at the base of her brainstem and where she had the tumor and surgery. So she had, you know, the $1 million workup. Anal rectal manometry, for those of you who are not familiar, is a test where they insert a balloon in the rectum, they check your sensation as they fill it, and then they check your ability to empty that balloon as if you were emptying a stool. It's very common, at least in our practice, as pelvic physical therapists, that patients who are diagnosed with kind of constipation or maybe an outlet type obstruction constipation are automatically assumed to have pelvic floor coordination deficits and inability to evacuate their stools because of their pelvic floor, so thinking that that pelvic floor just wouldn't fully relax. Her manometry was completely normal. She had had 2 previous courses of pelvic PT, quite extensive courses of PT that were only focused on biofeedback, yet she could control the muscles, okay? The testing that was very pertinent, like highlighted in here, is the SITS marker study and the gastric emptying study, where they look actually at that transit time along the colon. And both of those were significantly delayed, with the delays mostly found in the left transverse, the descending, and sigmoid portions of the colon. She, accordingly, because of this slow transit constipation then diagnosis, was taking several medications in an effort to stimulate the colon to get going, right, to promote that peristalsis. So she was taking Trulance, Amitiza, Linzess. Coltracine, interestingly, is a gout medication, and that was really prescribed because of all of her bloating. So when she wouldn't have bowel movements for several days, she also would get a ton of lower extremity edema and swelling as well. And the Mestinon is actually typically prescribed for myasthenia gravis, and was partly for her motor coordination, but they also were thinking it might stimulate some of the colon function as well. So this is just a little schematic for those of you who aren't familiar. The SITS marker study here is showing that you basically take this little radio-opaque capsule that has all these little markers in it. And then what they do is at like a day, at 3 days, and at 5 days, they go and they take an x-ray to see where those markers sit. And if you are passing normally and have normal colonic transit, they should all be at the end of your rectum or empty within day 3, right? But if they don't move well, then they kind of are all spaced out or kind of pool in different regions of the colon. And it's the same thing with this gastric emptying test here. The top portion is showing someone who's healthy, who within 48 hours, that food moves. And on the bottom part is showing someone who has that slow transit constipation where it's you can see it's delayed, right? And by 2 days, it's still in the transverse portion and hasn't kind of kept moving through the system. So what do we do with that, right? And what did I find on her exam? So in her exam, as you can see on the bottom here, that I say, like, her pelvic floor motor control was perfect, right? She could contract the pelvic floor the right way, relax it the right way. I did biofeedback to dot my I's and cross my T's, even though she'd had it before. But really, she had very pronounced soft tissue restrictions throughout her colon, especially along the transverse and descending portions. She had a lot of tension in her iliopsoas and rectus abdominis muscles, and a very, very acute rib angle. So probably about 60 degrees, so a very narrow angle, and really had a hard time expanding her diaphragm on inhalation, and would even say that she often felt like short of breath with that constipation because she couldn't really breathe more. She just didn't feel like she had any space. So, you know, when I first started working with her, I talked to her a lot about diet, exercise, toileting posture, things that I would do with anyone who has constipation. I did 1 or 2 sessions of biofeedback to rule it out, to make sure I wasn't missing anything. And then I really focused on manual therapy. So I really worked on the abdominal musculature. I did a lot of visceral mobilization of the colon, small intestine, to try and get things moving, and really focused on opening up the diaphragm and doing some diaphragmatic breathing. So with all of this, she definitely got some relief and felt better, was maybe going a little bit more frequently, but I think what I was really doing was helping manage some of the pain at the outset. So then what I did was, after, I usually kind of give myself, this is just my personal style, I usually kind of give something a solid 4 to 6 weeks before I kind of move on to another intervention to really see if something helps or not. So then the next thing I kind of layered onto that was I tried using TENS over her colon and over the sacral nerve roots. So they're, given that she has slow transit constipation and it is nerve related in nature, I was trying to stimulate that kind of colonic peristalsis to get moving. So we tried it over the abdomen as well as over the sacrum. It did help a little bit, and I think had an initial effect. She liked it, it did help improve the frequency of bowels, probably for the first maybe 4 to 6 weeks, and then it kind of tapered off. Interestingly, she also had symptoms of really not fully emptying the bladder, and the TENS really helped with her emptying the bladder. She would always say it really helped with that more than it did her bowels. So then enter the WINBACK, right? So I believe we got the WINBACK probably 3 or 4 months after I had started working with this particular patient. And so, we had a demo from one of our representatives from WINBACK who came and showed us how to use the device and told us about kind of the different treatment protocols. And so I kind of figured, why not give it a try? And I started to use it in conjunction with kind of the visceral mobilization techniques that I would use along the course of the colon and along the inferior border of the rib cage where her diaphragm was really restricted. And I kind of tinkered around with the capacitive and resistive modes. This particular patient tolerated the capacitive mode more, just from a preference standpoint. And I kind of would use it as a pre and post to my manual treatment. So I would kind of sandwich my manual techniques with the WINBACK. This is the protocol that WINBACK provides for constipation, for that slow transit constipation, and it's similar to on principle the manual techniques I was doing. So for those of you out there who are familiar with visceral mobilization techniques or kind of Barral techniques, the WINBACK protocol kind of follows the same thought process of first kind of stimulating this Cannon-Bohm zone, which is at the intersection of the superior mesenteric artery and the transverse colon. So you would do that for about 2 minutes. Then you would actually try and release the ileocecal valve and then the different anchoring points of the colon, so at the rib cages. So again, it kind of like followed suit with what I was doing already manually, just without this added deeper stimulation. And then you would end with kind of this like clockwise like colon massage, potentially using the bracelet resistive mode. So the goals with the WINBACK and like why I even brought this in was, in my head, I was thinking, hopefully this will help promote some blood flow to the colon. It will help remove the colonic motility and really reduce the restriction. So like give her a little bit more movement. And it did, right? Like she so the take home from this is she gets immediate pain relief after using the WINBACK. It lasts for several days. And it's remarkable how much her bloating reduces after a session when I add in the WINBACK with it. She also, so now I have been seeing her for well over a year, really as maintenance. Probably I see her about once a week, and really do a ton of manual therapy in the WINBACK. And before she even comes back, she's like, do you have the machine? She, really relies on it now, because it really has let her go more frequently. So she has a bowel movement now, probably every 2 days on average. But this has been really a game changer for her. And I've noticed it's been a game changer for these type of patients, when you're really trying to mechanically move things along with the constipation. So that's my case. We're going to have a bunch of time for questions at the end. I'm going to let Teasley take over and explain some of their techniques and cases.